This recording will continue the lecture on physical assessment of children. Anthropometrics entails measuring the human body and assessing nutritional status as well as growth and development. Weight, height, and head circumference are always measured in children and are compared with averages for age group and gender. The amount of body fat should be measured on the basis of the body mass index, BMI. Mid-arm muscle circumference, skin fold thickness, and weight provide information about three body tissues: subcutaneous tissue, muscle, and fat, altered by nutrition. Because children's body fat varies with age and gender, anthropometric measurements are the most valuable when plotted on a growth curve and evaluated serially so that trends can be monitored. Measuring height, weight, and BMI are routine procedures that provide valuable information about a child's health. Children grow and develop rapidly, and this growth and development must be constantly evaluated. A child's serial physical measurement reflects the rate of growth. A failure in growth, an acceleration in growth, or any changes in growth pattern can be the first clue to serious health problems. When a child's weight or height stops following the child's own growth curve, this is the most significant indicator of a change in health status. Measurements must be correct and accurate and are taken at every visit from birth to adulthood. Documentation of measurements provides an accurate record of a child's overall pattern of growth. The CDC provides growth charts, a series of percentile curves for selective measurements which are used to assess body size and monitor growth in infants, children, and adolescents in the United States. Separate sets of growth charts are available for girls and boys. The World Health Organization growth charts for ages birth to age 2 years plot length, weight, and head circumference measurements for age. They also plot the weight and length relationship, which can be used as an indicator for overweight or obesity in children. The CDC charts for ages 2 through 20 years plot measurements of height, weight, and BMI for age. BMI is used primarily to screen for children who are overweight, although it can be used to describe children who are underweight. Special growth charts for premature, very low birth weight infants and children with special needs are available, but may be based on old or inconsistent data. Normal growth charts can be used with the infant's age corrected for gestational age. Plotting on a growth chart proceeds as follows. The child's exact age is located on the chart's horizontal axis. The corresponding measurement is located on the chart's vertical axis. The chart is marked where these two lines intersect. The percentile lines on these charts indicate the number of children whose measurements are expected to fall above or below the child's measurement. Weight and height measurements above the 97th percentile or below the 3rd percentile on the standard growth chart indicate a growth disturbance that needs further investigation. Brain growth can be assessed by serial head circumference measurements. In regards to height, infant and toddler length is best measured with the child lying down on a flat measuring board. This method is used until the child is able to stand independently. The child's head is held securely to the headboard, and the movable footboard is stretched to touch the child's heel. If a measuring board is not available for the infant or young child, it is possible to position the child's body on a flat surface, mark the point where the heel touches the surface, and then mark the point where the top of the head is lying on the surface, taking care to ensure that the child's legs and body are straight on the surface. The examiner then removes the child and measures the distance between the 2 points. Measuring the length of a child in this manner is not as accurate as using a measuring board. Anthropometric measurements reflect any change in the growth pattern and may be the first clue to a serious problem. Measurements must be taken at every healthcare visit from birth to adulthood. If a child's weight or height stops following the child's own growth curve, it is a significant indicator of a change in health status. When a child is able to cooperate and stand without support around the age of 2, the examiner stands the child in stocking feet, so just their socks on, next to a standard measuring tape that begins at the child's heel and is not displaced from room molding. A flat, hard surface is used to reach from the top of the child's head to the tape so that the examiner does not guess or add height because of hair. If with the first standing measurement, there may be a slight discrepancy from what the last lying measurement had been. Once the measurement is taken, it must be plotted on a standardized growth chart appropriate for length or height measurement. Height and weight are evaluated by determining whether the child is following a predictable percentile curve on a growth chart. In terms of weight, all scales must be balanced or zeroed first before weight is measured. Infants are placed in the lying position on a regular baby scale with all their clothing removed. Older children who are able to stand or walk without support may be weighed on an adult standing scale. On the older child, remove all clothing except underwear. In regards to head circumference is measured in all children from birth to age 36 months and is plotted on a standard growth chart on all visits. Head circumference can reflect an abnormal rate of development, give some indications of nutritional status, and possibly indicate tumor growth or abnormal accumulation of cerebrospinal fluid. Any marked increase in head circumference measurements during infancy requires referral for evaluation. Chest circumference is routinely measured only in newborn infants. And here you see a picture of a baby getting his head measured there, his head circumference measured. We're going to skip forward now to assessment of the head. Head movement is evaluated by observing the child's spontaneous head movement. Head control is observed when the infant in a supine position and while the examiner grasps the infant's hands and pulls the infant into a sitting position. An infant younger than 4 months may show some head lag or the head falling back, but the infant in an upright position should be able to maintain the head upright for several seconds. Head lag after age 6 months suggests poor muscle development. The fontanelles are inspected and palpated for size, tenseness, and pulsation. The posterior fontanelle is closed by age 2 to 3 months. The anterior fontanelle should be soft and flat when the child is sitting. Measure the width and length of an open anterior fontanelle. The anterior fontanelle should be less than 5 centimeters in length and width after age 12 months and should be completely closed at approximately 12 to 24 months of age, with the average age of closure being 18 months. A sunken fontanelle is associated with dehydration, where a bulging fontanelle is associated with increased intracranial pressure. A bulging fontanelle is normally seen when a child or an infant cries, coughs, or vomits. Inability to palpate the anterior fontanelle may be an indicator of premature closure. In regards to teeth, the eruption of deciduous or baby teeth begins around the 6th month of extrauterine life. All 20 deciduous teeth are present by age 30 months. So baby teeth erupt around 6 months, and they're all 20 of those deciduous or baby teeth are out by the time the child reaches 30 months of age. In regards to vision, I want you to be familiar with box 33.8, types of eye charts. So the Snellen chart you're used to, that's what you use when you go to the eye doctor, that has all the letters on it that assesses visual acuity. Obviously with children who might not know their alphabet, the Snellen chart might not be able to be used. So there's some different types of charts that are shown on box 33.8. The Lee chart uses different symbols, can be used for preschool age children. The HOTV chart is shown with a little girl demonstrating that in a picture in that box where she's pointing to the letter that she sees. Ishihara doesn't assess visual acuity. The Ishihara chart assesses for color blindness. It's the designated to test for colored vision between ages 4 and 6. Color vision is evaluated using the Ishihara charts, a series of polychromatic charts, so cards. If you remember those, they have the little dots with different colors on it, and if you have normal vision, you can see the number that's within the picture. These cards have a pattern of colored pictures embedded in the charts. Children between ages 4 and 8 are tested once and are asked to touch or identify the embedded patterns. A child with color blindness will not be able to identify the pattern or the number that's presented in the chart. In terms of ears, in a child younger than 3 years, the ear canal is straightened by pulling the pinna of the ear down and back. If a child is 3 years or older, the pinna is pulled up and back. So you want to know how to pull on the ear in order to visualize the ear canal well. Another thing worth noting, if you do ever use an otoscope to examine, if you notice how they have their hand positioned on the child's head, that way, you know, this can tickle and the child can flinch. If the child moves, the provider's hand moves with the child, and that way decreases the odds of that scope touching the tympanic membrane and causing any injury. And finally, if you look at table 33.3, gross motor development and the infant progression to walking, please review that table. It goes over how the child progresses developmentally in order to be able to walk. So initially raises his head, then able to sit alone, then can crawl, then pull up. You know, it just goes over those standard developmental milestones, and I want you to be familiar with those. So here's a practice and NCLEX question. Go ahead and pause the video and read it. For this question, the correct answer is C.